Welcome to the show where we share the stories of the many who intersect with our healthcare system but are rarely heard from. My name is Kevin Poe, founder and editor of KevinMD. Rate and review the show at kevinmd.com/rate. Subscribe at kevinmd.com/follow. Today in the show, we have Audrey Shafer. She's an anesthesiologist. Her KevinMD article is titled The Sick Patient and the Anesthesiologist. Audrey, welcome to the show.
Thank you so much for having me.
We'll get into the article in a little bit. First off, briefly share your story and journey to where you are today.
I grew up in Philadelphia in a single parent family. It was my mother, my sister, and me. It was a very arts intensive family, which translates to not much money. My sister and I wound up being very interested in science and ultimately medicine, and we both became physicians. I think there's a lot of stability in that. And I am currently, and have been for quite a while, on faculty at Stanford in the Department of Anesthesiology, Perioperative and Pain Medicine. And my clinical work, though, is all at the Palo Alto Veterans Hospital. My academic work has focused on an area that's called medical humanities, which is like bringing the arts, humanities, qualitative social sciences to bear for us to better understand what it means to be human, mortal, embodied, and to care for each other when we're ill.
We'll talk more about that intersection between the humanities and medicine. Why is that so important?
You know, I think what I hope to do in my writing about anesthesiologists is to show that even in this highly technical field of medicine, the human element is paramount. And what I believe that the arts and humanities do is to broaden our view of what it really means to be human in this very diverse world. It enlarges our view much more than one can do just in living one's own life. And hence, I believe that the arts and humanities hold this ability to not only broaden your view, but also deepen it and allow you to think critically about what it is that we do in medicine.
All right, and we're going to talk more about one of your stories in your KevinMD article titled The Sick Patient and the Anesthesiologist. Now, for those of you who get a chance to read your article, just walk my audience through it. Share the story, why you decided to write it.
I wrote it because in this world of anesthesiology, we don't have a great span of time to get to know our patients. Frequently, the patient has either not had a preoperative evaluation or there is one that's in the electronic record, but one is meeting the patient immediately before they're going to go in for their procedure. And I wrote this article because I wanted people to understand that the anesthesiologist cares deeply. And in my practice, we do have the sick patient, the one who is struggling to breathe even before going in for anesthesia and for some sort of invasive surgery. And that this is of concern. So when an anesthesiologist expresses concern, it's out ultimately for a love of that patient, for caring that patient is done right by. And the other wonderful thing about the patient population in my practice is that our patients are amazing. It is a diverse population, all adult, but many ages, different walks of life. But there is this population of people who are very self-reliant, who are used to only depending on themselves. And so this aspect of giving a stranger control over their life can be pretty disturbing for our patients. They're not going to express it that way, but that aspect of control is important to these patients. And so I wrote this article that's based on a number of patients, a conglomeration out of just deep love for the patient population I serve.
So when a lot of people think about anesthesiology and anesthesiologists, the proverbial response is that they're just behind a drape. during a
Right.
surgery or some type of procedure. But anesthesiology is so much more than that, right? There's outpatient pain clinics, there's perioperative clinics. So talk more about the non-operative room setting of what anesthesiologists do. Tell us a little bit about some of that.
Absolutely. There are all kinds, as you say, there are all kinds of subspecialties within anesthesia, some of which are operating room based, like cardiac anesthesiologists or neuroanesthesiologists, that sort of thing, but others which expand out into the rest of the hospital. Pain medicine, which has a clinic component to that and extended visits with patients over time. There's critical care, the intensive care unit, that anesthesiology is a pathway to becoming an intensivist. There is regional anesthesia, which is frequently linked to the operating room, but which also those specialists take care of acute pain issues in the hospital. And there's obstetric anesthesiology, which cares obviously for people who are about to have their baby. Other subspecialties include pediatric anesthesiology. So some of our anesthesiologists are board certified in multiple areas in order to qualify to handle patients in those very subspecialized, intricate areas of anesthesia.
So I'm going to ask a question that puts you a little bit on the spot here, but can you think about a case or a patient that really demonstrates that longitudinal relationship an anesthesiologist has with a patient that really illustrates some of those other settings that you talked about?
At my hospital, I'm part of the perioperative medicine team. And so what we do is we go to see the postoperative patient. Frequently, the anesthesiologist who's actually had provided care for that patient is in the operating room with other patients. And so we have a team who goes around, and it's part of our teaching program through the Stanford Anesthesiology Residency Program, where we meet with patients. So for example, I had a recent patient who I had seen seemed perfectly fine when I interrupted his breakfast in the morning, and sometimes unfortunately one is like finding patients asleep and wondering, they look good, maybe I should come back in a little bit so they can get that restorative sleep. But anyway, he had seemed fine, only for me to hear maybe 2.5 hours later, an E-team, and as perioperative medicine, you're part of the rapid response team, went to this E-team for this patient. He was not doing so fine. So things rapidly changed, but the fact that I had seen him and could report what his vital signs had been just a couple hours before was helpful. He did fine. We continued to follow him, and he went home just fine. But that is the kind of thing that being able to see somebody at multiple windows, and of course the nursing care, because they are following patients and are with patients, are very helpful with those reports to the E-team. We call them E-team in our hospital, or rapid response team. So that is the kind of thing, and also just an understanding of how long the anesthetic effects might be expected to last, because frequently people will say, oh, that's due to the anesthesia, but really most of that anesthesia is going to be gone. So to eliminate some of the potential issues that people are thinking of.
Now, you said in a lot of cases, anesthesiologist sees patients only in small or relatively small windows of time. What are some techniques that they can use to deepen that relationship, even though they only see patients transiently for short periods of time?
That's a really great question. And I think that people who gravitate towards this field have the capacity to listen and to allow the patient to express themselves as fully as possible. Even though there's a short period of time, it's important that we take our time and not appear rushed at all. And I think that is picked up really easily by the patient. So settling in, another aspect besides really being interested in listening that our anesthesiology trainees have is the ability to focus. So One of the absolutely lovely things about being an anesthesiologist is that you are given this gift of being able to focus on one patient. And you know that you cannot leave the operating room when you're anesthetizing a patient. It absolutely is not going to happen. So this focus on the patient starts as soon as you meet the patient. And I think they respond to that you are fully there and want to hear what their concerns are.
We're talking to Audrey Shafer. She's an anesthesiologist, and her KevinMD article is titled The Sick Patient and the Anesthesiologist. Audrey, we have a wide spectrum of medical specialties who listen to this podcast. Are there any misconceptions or misperceptions about anesthesiology and anesthesiologists that you'd like to clear up?
Absolutely. I think you mentioned one that sort of the drape goes up and the anesthesiologist is maybe twiddling their thumbs or something on the other side of the drape. This does not happen. It's a practice where we become the eyes and ears and senses for the patient throughout. And really, the anesthesiologist views their role as a protector and guide for the patient. Yes, we try to appear calm and collected even during crisis, but really there is intense attention being paid, and to respect that we are colleagues who are interested in being fully informed of any changes that occur during a case and things like that. So yes, you are correct. I think there are probably misconceptions about every specialty, but being an anesthesiologist, I think I'm more sensitive to those that occur about my sphere.
And my final question, what are some of your take-home messages that you want to leave with the KevinMD audience?
I'm a teacher, and I would just like to encourage anyone who is considering going into medicine, who is in medical school, who is trying to decide what to do, that because anesthesiology rotations tend to be elective and you don't really know what you love until you are immersed in that area, that I would encourage all those people to at least take a 2-week elective in anesthesiology. It will help to let you know whether you yourself are interested in it. And no matter what specialty you go into, it enables you to understand what your patients are going to undergo when they have procedures which require anesthesia care. So I think that is my message. And to anyone, as I have recently had to experience anesthesia and surgical care myself, physicians are patients too, and that your anesthesiologist cares for you.
Audrey, thank you so much for sharing your time and insight. Thanks again for being on the show.
Thank you.